Branch President Dr. K. Anil Kumar garu to dais. I am delighted to introduce our chief guest and speaker, Dr. N.V. Sundaracharya garu. He is an accomplished person in the field of neurology. His methodical, patient-centric approach and his concern for the poor and his strict adherence to medical ethics and his sacred commitment to mass transfer all the wisdom to young aspirants around are something phenomenal. We are honored to have Dr. N.V. Sundaracharya sir here tonight to share his knowledge and clinical experiences with us. I am confident that this interaction with Dr. Sundaracharya sir will be a valuable learning opportunity to all of us. It is my privilege to invite Dr. Sundaracharya sir to come on forward and hold the chair. Sir. Anil Kumar garu, IMA Tenali Branch President to preside the chair. And
today we are gathered here on this evening. There are few coincidences where the Dr. Seetha Ramamma garu, he did her undergraduation in our college, Guntur Medical College, and here we are honoring our chief guest, Dr. Sundaracharya garu is now the principal of the same college, Guntur Medical College, and she travelled all together to the US, where the east meet the west, but still she practiced there, and it's a good example where the science is equal whether it is the east or west. And now I request our chief guest and all the members to attend the floral tribute to Dr. Seetha Ramamma garu. I request family members of Dr. Seetha Ramamma garu onto the dais for gold medal presentation to our chief guest. I request Dr. Dakshinamurthy garu and Kishore garu also. Kishore garu. Onto the dais for a few words
a research-minded professor. He published many articles in national and international journals. Last time when he came here, I missed him his speech because out of station. Now I came here to introduce the donor. Please get up. Because most of you don't know Dr. Vadlamudi or Babu. He belongs to Mopar. His father, freedom fighter. Vadlamudi Gopalakrishna garu. Vadlamudi Gopalakrishna garu. Vadlamudi Kotai garu, famous pleader. Trust is there now. Vadlamudi Nageswara's father. Vadlamudi Radhakrishnamurthy's father. All these people, they belong to same clan. Why, how my acquaintance with him is, we used to walk, please sit. We used to walk in TJ College for the last 15 years, 20 years. For the last 10 years, he was also coming every January and July to India. Then he used to come to walk briskly, more briskly than us, and also used to go to Pedrauru by brisk walking. We used to stop at TMJ Junior College. Then he is a famous psychiatrist, very well learned and very talented. Child psychiatry, forensic psychiatry and general psychiatry, so many departments he is efficient. And also it is unfortunate that his Mrs. She belongs to Guntur Medical College, Somaraju batch. Unfortunately, that is the only loss to him. There is no, he is perfect in Dehadarugyam, speech. Repu Krishna Gari speech ki pilcharu varni mana Anil Kumar. Meeru Vindur gaani chaala baga maatladtaru, subject gaani, literature gaani. We are interested in old films also. He is having some 3,000 cassettes with him. Old films, not new films. Therefore, we are thankful to him for donating 5 lakhs to IMA to commemorate his wife, Dr. Ramamma. Very unfortunate that she passed away. So, this is to introduce Dr. Vadlamudi.
Date of Dr. Seetha Ramamma garu.
Biodata of Dr. Seetha Ramamma Vadlamudi. Seetha Ramamma Vadlamudi, MD. Date of birth August 24th, 1948. She is the fourth daughter of Namburi Subbaya Garu and Narasamma Garu of Bapatla. She completed elementary school education and pre-university education at Bapatla. Joined in Guntur Medical College during the year 1964. Obtained MBBS degree in 1970. Worked as junior doctor with Dr. Sajja Chandramauli at Nidubrolu from 1970 to 1972. Married to Dr. Babu R. Vadlamudi, MD, on 3rd May 1974. She did private practice at Bapatla from 1972 to 1980. Worked as house doctor at Plymouth General Hospital, Detroit, Michigan, USA from 1980 to 1981. Completed rotatory internship at Detroit Memorial Hospital and South Macomb Hospital, Michigan, USA. Worked with Spectrum Emergency Care as an emergency room physician at several ER facilities in Michigan from 1982 to 1989. She did her residency in family practice at St. Elizabeth Hospital, Utica, New York from 1989 to 1992. Worked as medical care physician at Clinton Valley Psychiatric Center, Pontiac, Michigan, 1992 to 1995. Worked as a medical care physician at Huron Valley Psychiatric Center, Ypsilanti, Michigan from 1995 to 2004. worked as a medical director at Woodland Correctional Facility, Michigan from 2004 to 2014. She retired from Michigan State Healthcare Services in 2014. Expired on 6th December 2020 at her Bingham Farms residency in Michigan, USA. Dr. Seetha R. Vadlamudi Memorial Gold Medal Lecture on 24/1/2025.
Privileged to introduce Dr. N.V. Sundaracharya sir, and he did his MBBS from Guntur Medical College and did MD Pediatrics from Andhra Medical College Visakhapatnam, did DM Neurology from Usmania Medical College Hyderabad. He contributed his services as Assistant Professor from 1991 to 2004 and Associate Professor from 2004 to 2011, Professor from 2011 to present date, and he worked as and contributed as additional DME and present holding the prestigious post of Principal Guntur Medical College, and he did ADME and Principal of GMC Machilipatnam from 2003 to October 2024. Present Principal of Guntur Medical College from November 2024 to present. Sir has many achievements in his kitty and is academic senator for Dr. NTR Health University, Fellow of Indian Academy of Neurology, and awarded State Best Teacher Award for the 2023 year. Achieved the specialty certificate from Royal College of Physicians of United Kingdom Association of British Neurologists in 2022. Fellow of American Academy of Neurology, FAN. And Sir is one of the best clinician, academician, and has a lot of commitment towards patients, especially in poor patients. I personally known Sir also, and his contributions are phenomenal. Thank you very much. It's time to important time, and I invite Dr. Sundaracharya sir to deliver speech on topic of spectrum of movement disorders.
Respected family members of Dr. Vadlamudi Seetha Ramamma, Dr. Rajendra Babu garu and their daughter, senior members of IMA of Tenali, Dr. Patimandla Dakshinamurthy garu, my senior, my well-wisher, Dr. Sambireddy garu, and other members of today's gathering in this IMA hall. A very good evening to all of you. Indeed, I feel extremely honored and extremely happy for asking me to deliver an endowment lecture, gold medal lecture in memory of Dr. Vadlamudi Seetha Ramamma. I belong to 1981 batch of Guntur Medical College. She joined in the year 1964 when I was born in 1964. That is a coincidence. When she joined in GMC Guntur, I was born. I am very happy. And I am going to present the rarest of the rare cases, not the carbon copy of the theoretical background. All these cases were treated by us in the Department of Neurology. The title is Spectrum of Movement Disorders. They are very rare. They are recognizable with the classical findings, and these classical findings are specific to these rare disorders. On this occasion, I want to quote Oliver Sacks, a famous neurologist from British, spent his time in USA. He's not only a neurologist, he was a professor, laureate and writer. He said, please, while examining disease, we gain wisdom about the anatomy, physiology, and biology. While examining the person with disease, we gain wisdom about life. That is his quotation. I liked it and I wanted to show this. I have some 20 to 25 cases with videos. Here is a first case, 32-year-old male patient presented to us with fever and joint pains, altered sensorium, and imbalance while walking. That is ataxia. Video, it will play with them. Video. This patient has opsoclonus, myoclonus, and severely ataxic. The syndromic diagnosis was meningoencephalitis with opsoclonus, myoclonus, ataxia syndrome. Investigated, and we could not find the reason. We thought of Lyme disease. Lyme disease is an extremely rare condition. Lyme disease means borreliosis. This disease was described in the city of Lyme in Connecticut. This is caused by Borrelia burgdorferi. It's a tick-borne disease. Till 1975, this disease was not recognized. And many people think that it's not seen in India, but I have seen plenty of cases of Lyme disease. This is an example of Lyme disease presenting as meningoencephalitis. The clinical picture is opsoclonus, myoclonus, ataxia syndrome. And I have sent the sample for antibodies. IgM antibodies were significantly raised. The diagnosis is confirmed. And he responded dramatically with doxycycline and ceftriaxone. Has become normal. This patient completely recovered at the time of discharge. So what I want to say in this case is Lyme disease, we have to have a high index of suspicion if the clinical picture is not typical. We have suspected Lyme disease because he had joint pains and fever. The second case, 3-year-old female child with fever of 1 month ago that improved with oral medication, and that was followed by street dog bite 1 week later of the onset of fever. And she was administered 3 doses of ARV on day 1, day 3 and day 7. After the 3rd dose, parents noticed abnormal eye movements and swaying while walking. Examination was normal except opsoclonus, truncal ataxia, and her plantars for extensor. CSF was normal, MRI was normal, routine tests for fever were normal, NMO was negative, MOG was negative. See the video. She has opsoclonus, she had truncal ataxia. It's a case of post-vaccinal opsoclonus ataxia syndrome She was put on steroids and she recovered completely. So it's a case of post-vaccinal opsoclonus ataxia syndrome. That was a case of opsoclonus myoclonus ataxia and encephalitic picture. That was a Lyme disease case. This is post-vaccinal. Both recovered very well. The third case, she was 14 years old adolescent. The complaints were new onset seizures, absolutely asymptomatic 10 days before the presentation to us. New onset seizures, fever for 10 days, and behavioral changes, oral dyskinesias. Autoimmune encephalitis, anti-NMDA antibody encephalitis. This is not uncommon. 80% of cases are seen in women, and the outcome is excellent in 80% of cases. And most of them, they present under 45 years of age. It is a paraneoplastic disease. The most common tumor in this condition is ovarian teratoma. So any adolescent girl, young adult woman presenting with behavioral problems, orofacial dyskinesias, seizures of short duration, one should think of anti-NMDA encephalitis. It's a treatable condition. She responded to steroids. See, the receptor antibody was strongly positive. The reference is negative. So, it's an eye-opening. One should think of young woman presenting as acute encephalitic picture. CSF can be normal. The clinching points are orolingual dyskinesias and behavioral problems. It's an autoimmune disease. Here is the fourth case. 40-year-old male school teacher presented to us with muscle cramps and myalgias of both lower limbs, and they were not relieved with rest, and the duration was 6 months. On examination, had twitches all over the body and present during activities and even at rest. This gentleman had symmetrical action tremors of both upper limbs, and he had weight loss of 7 kg in 5 months. He also had been suffering from insomnia, and he said he was having hyperhidrosis, excessive sweating. On examination, see, the rippling movements of the muscles, the entire body is affected. This is called continuous muscle fiber activity, also called myokymia. The needle EMG shows repetitive discharges. They are myokymic discharges. So this man had myokymia, that is continuous muscle fiber activity, insomnia, hyperhidrosis, and weight loss. This is a case of another autoimmune encephalitis due to antibody produced against voltage gated potassium channel. So, It is also called Morvan's disease. The antibody is produced against voltage gated potassium channel, and this antibody is called Casper-2 autoimmune encephalitis. He responded dramatically to steroids. The fifth case, 65-year-old male, habitual binge alcoholic and smoker. He consumed huge quantities of adulterated alcohol, and next few hours he developed vomiting, an episode of blurring of vision. He was brought to emergency room, but glucose levels were normal, and his sensorium improved with simple medical management. And next day has become conscious, but on examination he has hypomimic faces, that is expressionless faces, reduced blink rate, hypokinetic dysarthria, has rigidity of the entire body, generalized rigidity, and he has bradykinesia. It's a case of acute Parkinsonism. Induced by methanol. Toxic Parkinsonism. Methanol has resulted in Parkinsonism. See, this is his MRI picture showing hyperintense signals in the bilateral corpus striatum. So there is hyperintensity of corpus striatum bilaterally. That has resulted in acute Parkinsonism. It is not idiopathic Parkinsonism. He recovered very well in a span of few days. He was discharged normally without any anti-Parkinsonin medication. It is a case of methanol-induced Parkinsonism, toxic Parkinsonism. The seventh case, she is 70 years old female, a case of idiopathic Parkinson's disease of 5 years duration. She was prescribed levodopa, and dopamine agonists, propinerol. Over the recent time, her medication was changed. The dose has been increased. And after increasing the dose of levodopa, she developed this type of this is nothing but peak dose hyperkinesia, peak dose dyskinesia because of levodopa. Levodopa, the commonest side effect is hallucination. It also results in other adverse effects like dyskinesias. So this is because of peak dose of levodopa. And adjusting the dose of levodopa, she has become normal. So the diagnosis is levodopa-induced dyskinesia. Most of the times, we use inadequate doses of levodopa. The recommended dose of levodopa is 2 to 3 grams, but we give lesser doses, 125 mg TAD, maximum QAD. We need to give 2 to 3 grams for adequate response of Parkinsonism. Parkinsonism is due to the deficiency of dopamine. It is a chemical disorder because of the deficiency of dopamine. So we have to supplement dopamine by giving levodopa, but there will be adverse effects like peak dose dyskinesia. So we have to slowly increase the doses of levodopa. Another case, 25-year-old male, born of second degree consanguinity, presented for abnormal movements of all the limbs, difficulty in swallowing, lip and tongue biting. His younger sister was also suffering from the same illness. Remember, he was born of consanguineous parentage. That means there is an autosomal recessive predisposition in this condition. Lip biting, tongue biting, and dysphagia, and coriform movements. This is the video. The moment he tries to swallow, his muscles of pharynx will go into spasm. This is called feeding dystonia. In addition to feeding dystonia, he has lip biting, tongue biting, consanguinity. It's a rare case of neuroacanthocytosis. Autosomal recessive condition, and suspicion is very important. With simple peripheral smear, we could make the diagnosis. See, the RBC are spiky. Spiky RBC means acanthocytes. So it's a case of acanthocytosis, autosomal recessive predisposition, and that is the video. Hyperkinetic movement disorder, dystonia, dyskinesia, tongue biting. And we have confirmed the diagnosis by genetic analysis. It came positive. It's a case of chorioacanthocytosis, autosomal recessive condition. But unfortunately, there is no satisfactory treatment for this genetic disorder. Only we can give symptomatic treatment for chorea, tetrabenazine like that, and pacitine. So it's a case of chorioacanthocytosis, autosomal recessive condition. And here is the 9th case, 25-year-old female. She was also born of second degree parentage. The complaints are abnormal movements of the hands, awkward movements of the hands, repetitive movements of the hands. That is called stereotypy. And she was also having behavioral problems. She could not make eye contact, and she had anger outbursts, temper tantrums. And her imaging was completely normal. See, this is the video. So, there are stereotypical hand movements. This is a case of Rett syndrome. Rett syndrome is an X-linked condition. It is seen only in girls because boys cannot survive. It is an X-linked dominant condition. And it is a developmental disorder. They have microcephaly, they have scoliosis, they have language arrest, and they are prone for seizures. The classical feature is hand stereotypy. There is no coordination of hand movements. Instead, they will have stereotypical wriggling movements. This is the case of Rett syndrome. X-linked condition due to the and have sent for analysis, came positive for MECP2 gene. Methylene CpG binding protein mutation was there, and there is no satisfactory treatment of this Rett syndrome. We have seen not many, around 10 cases of Rett syndrome in the Department of Neurology. It's a developmental disorder, it's not a progressive disease. The point here is this mutation of MECP2 gene results in ineffective synaptogenesis of the brain. That's why they are mentally subnormal. They will not have hand coordination. They will have hand stereotypy, and they are prone for seizures. They have microcephaly, scoliosis, etc. Another case, 18-year-old male child born of consanguineous parentage presented to us with chronic progressive spastic quadriparesis, dysphagia and dysarthria. See, he was short-statured, he was having a short neck. I have asked him to make movement of the right hand. While moving the right hand, he was also having the movements of left hand. This is mirror movements. This child was short-statured, he was having short neck, upper motor neuron type of quadriparesis, and involvement of tongue, lower cranial nerve involvement. The anomaly is CV junction anomaly. Why it happens? Because of the ineffective crossing of the corticospinal tracts in CV junction anomaly, some fibers will not cross to the opposite side. That's why when you ask him to move one hand, there will be movement of the other hand also. This is classical finding, CV junction anomaly, ineffective crossing of the corticospinal tract, a clinching point for the diagnosis of CV junction anomaly. These movements are mirror movements. See, this man was 40 years old, RVD positive. He presented to us with slowness of activities, that is bradykinesia, of 2 months duration, with disturbance in memory and change in his behavior. So, we thought in terms of the clinical diagnosis of dementia. We were on the process of investigation. See the palms, hyperpigmented rash, and this is the video. See, he's sucking the lollipop. This is specific to neurosyphilis. And when we went back to the history, he had ulcer over the glans penis, and it was painless, and it was treated with penicillin. So it's a case of neurosyphilis. This sign is called candy sign of neurosyphilis, specific to neurosyphilis, as if he's sucking the chocolate. The other case, 23-year-old female, born of second-degree consanguineous parentage, presented with ataxia of gait, intention tremor of upper limbs, ataxic speech. On examination, she was having upper motor neuron type of weakness of lower limbs, that is paraparesis, and dystonia of the index fingers, without sensory, cerebellar, or cranial nerve involvement. See the fundus, this is cherry red spot. This is the video. It's a case of Niemann-Pick's disease, deficiency of sphingomyelinase, accumulation of sphingomyelins in the liver. and have sent the blood for genetic analysis. It came positive. Niemann-Pick's type C and type D. There are 6 types of Niemann-Pick's disease, and it's a case of Niemann-Pick's type C and type D also. Autosomal recessive condition. Presentation is ataxia. They have hepatomegaly, splenomegaly, and the classic fundus picture is cherry red spotting and dystonia of the index fingers. Another case, interesting case, 14-year-old boy born of second degree consanguinity, presented to us with delayed milestones, recurrent episodes of jaundice since infancy. He had recurrent episodes of epistaxis also. In an examination, he had abdominal distension and dilated veins over the abdomen and also over the chest. He presented with severe headache and seizures of 3 months duration. See, this is the abdominal distension, gross hepatomegaly, splenomegaly, engorged veins over the abdomen. This boy had tics, oculomotor apraxia, and the horizontal saccades were completely absent, and imaging showed hydrocephalus in MRI. It is a case of Gaucher's disease, another autosomal recessive condition due to accumulation of glucocerebroside. The deficiency of enzyme is cerebrosidase. Another genetic condition, autosomal recessive condition, untreatable condition. So they will have visceromegaly, they will have headache, hydrocephalus, whatnot, everything. They will have recurrent epistaxis also. Here is a case of 12-year-old boy, no consanguinity, first in birth order, achieved all the milestones at appropriate age. He presented to us with repetitive blinking movements of the eyes for 1 year, and these blinking movements were aggravated during episodes of fever and recent history of febrile illness followed by aggravation of eye blinking movements. He also had jerky head movements, and remember, any abnormal movement with suppressibility is called tic. So this individual had tics, eyelid tics, and there were no other abnormalities involving cranial nerves, sensory system or cerebral system. His autonomic functions were normal and has no compulsions or obsessions or cognitive decline. It's a case of PANDAS syndrome. PANDAS means pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. The presentation is with tics. Some will have compulsions, some will have obsessions also, but this child was not having obsessions, only tics were the presentation. These tics were accentuated, aggravated with each episode of fever. It's not a genetic disorder. There was no consanguinity. His tics were aggravated by fever. It's a tic disorder, PANDAS disease, very common. You must have suspicion, otherwise difficult to detect. And we have sent for ASO titer strongly positive 420 units per ml, and the reference is 150 or less than that per ml. So it's a case of autoimmune disease presenting as tics disease, tics, multiple tics aggravated by throat infection due to streptococcal antigens triggering antibody cross reaction producing tics, PANDAS disease. Another case, 55-year-old man a smoker, alcoholic, presented with chief complaints of sudden jerky movements of right half of the body for 12 days before presentation to us. He was apparently all right 12 days before. Later, his complaint started as sudden jerky, brief movements of right half of the body with abnormal posturing. Initially, it involved right upper limb and lower limb. Later, it progressed to involve the right half of the face also in the form of eye blinking and deviation of angle of mouth to right side. Everything on right side only. And there was no loss of consciousness. It's not a seizure activity. And initially he had 2 episodes or 3 episodes per day, has increased to 100 episodes at the time of presentation. So this is the video. So that is the presentation. Faciobrachial dystonic seizures of acute onset of 12 days duration without loss of consciousness. See the EEG, bursts of spikes with EMG artifact. It's a case of autoimmune disease, antibodies to LGI antigen. See the MRI, there are hyperintensities involving the medial portions of the temporal lobes bilaterally but asymmetrically. It is another case of autoimmune encephalitis. That case was NMDAR encephalitis. This case is LGI1 antibody encephalitis. It is a treatable condition. He was prescribed steroids, completely recovered. See, LGI means leucine-rich glioma inactivated protein. It is another voltage-gated potassium channel disorder, strongly positive. So these investigations were not there before, sir. That's why I could not make the diagnosis of these conditions. So autoimmune encephalitis is a recent entity. I have been seeing the cases for the last 10 years only. And the literature also, they have described these conditions during the last 10 years only. Before, they were not described. Here is a 5-year-old girl born of consanguineous parentage, delivered by cesarean section. The indication was breech presentation because of delayed labor. She cried immediately after birth. There was no neonatal jaundice and there were no ICU admissions, and she was immunized as per schedule. The complaint was delayed motor milestones, delayed crawling, creeping, standing and walking. But she could attain language milestones, social milestones at appropriate age, only delayed motor milestones. The complaint of the mother was involuntary movements of the legs when she was trying to sleep. It's a case of paroxysmal hypnogenic dyskinesia. And she responded to clonazepam dramatically. Another case, 42-year-old Mashan without any comorbidities presented to us with cognitive disturbances with involvement of attention, executive dysfunction, learning problems, memory problems and perceptual problems, dysarthria, sleep disturbances and extrapyramidal features of bradykinesia. and there were no weakness, sensory loss or cerebral loss symptoms. There was no cranial nerve dysfunction. The problems were cognitive dysfunction involving these domains: attention domain, executive function, learning and memory, and perception. Other problem is dysarthria, and he had sleep disturbances. It's a case of rapidly progressive dementia, Parkinsonism with sleep disturbances. Another autoimmune disease. See the bradykinesia. See the expressionless faces. See the number of eye blinks. So clinically, it's a case of Parkinson's plus syndrome. In addition to features of Parkinsonism, he has features of dementia and sleep disturbances of acute onset, acute duration, not the duration of idiopathic Parkinsonism. See, this is the MRI showing cortical ribbon sign. See, the cortex is hyperintense, like a ribbon. This is called classical cortical ribbon sign. Generally is a feature of Creutzfeldt-Jakob disease. It is also seen in other conditions like autoimmune encephalitis, like this case. This is not a case of CJD. This is Iglon 5 antibody disease. Presentation is Parkinsonism, dementia, and sleep disturbances. And even today, this disease was not understood properly, what is happening, where it is acting, and the treatment is same as other conditions like the previously mentioned NMDA receptor encephalitis, steroids and immunosuppression has recovered completely. A 28-year-old male patient, alcoholic, gutka chewer, diabetic of 4 years, presented to us with slowness in daily activities of 4 years duration. Clear-cut case of young onset Parkinsonism, but in addition to Parkinsonism, he had dystonia. Dystonia means sustained posturing of a limb. Either sustained or ill-sustained, abnormal posturing is called dystonia. So this is the video. He is just 28-year-old. It's a case of NBIA. NBIA means it was previously called Heller-Warden-Spatz disease. Heller and Warden-Spatz, they were linked to Nazi, they were linked to Hitler. That's why those names were removed. It's a case of neurodegeneration with brain iron accumulation. There is accumulation of iron in the basal ganglia, producing dystonia and Parkinsonism. It is an example of Parkinson's plus syndrome. It was called Heller-Warden-Spatz disease in the previous textbooks. Now that name has been deleted. And we have sent the serum for genetic analysis, came positive. See, it's a case of neurodegeneration with brain iron accumulation. Autism recessive condition. Unfortunately, there is no satisfactory treatment for this condition, unlike Parkinsonism. Another case, 65 years old male patient, diabetic for 20 years, stopped using medication for 3 months, presented to us with complaints of large, flinging, violent movements. You know, it is a case of balismus. And sometimes there were involuntary movements involving both lower limbs also. It is called parabellismus. Hemibellismus or parabellismus. There was no history of fever. That means it is something related to high blood sugars. See the video. So it's a case of uncontrolled diabetes mellitus, stopped anti-diabetic medication. It is a case of diabetic steatopathy. The involvement of striatum has resulted in bellismus. Subthalamic nucleus of Lewy is a structure responsible for this bellismus. So here hyperglycemia, changing the metabolism of the basal ganglia, accumulation of iron results in bellismus. Treatable condition has responded to anti-diabetic insulin and tetrabenazine, has become normal. So it is a case of diabetic steatopathy. Presentation is bellismus. Bellismus versus chorea, only difference is amplitude. Chorea is not that violent. Bellismus is very violent. Last few slides only. A 4-year-old male child, born of non-consanguineous parentage. Remember, no consanguinity here. Normal birth weight, cried immediately after birth, uneventful neonatal period, but he was not vaccinated as per the schedule, and no history of fever, dog bite. He presented to us with trismus, rhizus sardonicus, stiffness of all the limbs, and stimulus sensitive, painful spasms of the limbs. It's a case of tetanus. See the trismus, see the rigidity, stiff limbs, and after treatment, has become normal. Don't think that tetanus is not seen nowadays. It is still seen. It's a case of tetanus. A 23-year-old female, seizure disorder, presented with seizures only. She was asymptomatic 10 days ago when she started having GTCS lasting for 2 to 3 minutes with tongue biting, urinary incontinence. See, the seizures resolved, but the patient was admitted with hallucinations. She was prescribed anti-epileptic medication, seizures subsided, but the second problem is she has been brought for hallucinations and they have gone to psychiatry ward. She was prescribed antipsychotics. 2 days later, she developed high-grade fever, altered sensorium as a side effect of antipsychotics. And temperatures were 104, 105 degrees sometimes. And see the carpopedal spasm. When the tone is increased in all the limbs, neck also, and posture also, there was axial rigidity. See the CT scan. CT scan was showing symmetrical calcification of the basal ganglia and the frontal, parietal, cortico-white matter junction. This is case of Force disease, Force syndrome, calcification of the basal ganglia because of hypoparathyroidism. See, the parathermone was 2.4, the adult values are 12 to 88 picograms per ml. She was having only 2.4 picograms per ml. So it's a case of hypoparathyroidism presented with seizures, corpopedal spasm, and calcification of the basal ganglia, and with the psychiatric manifestations, she developed NMS, neuroleptic malignant syndrome, as a side effect of antipsychotics. So basically it's a case of Farce disease because of hypoparathyroidism. Remember, hypoparathyroidism results in calcification. There is hypocalcemia, but there is a calcification in the brain. Contradictory. So, this is the final diagnosis. Hypoparathyroidism, CNS calcifications. These seizures were because of hypocalcemia. And as a complication, she developed neuroleptic malignant syndrome. She recovered completely. Last case, 38-year-old male presented with paroxysmal cervical dystonia lasting for 2 hours nearly. Each time during the episode had tachycardia suggestive of PSVT, and there is a documentary evidence of PSVT occasionally in ECG. Remember, all these episodes were occurring only during the period of GERD. Whenever he consumes food, there will be epigastric discomfort. He vomits. Sometimes it is with hematemesis, and his head goes into retrocolis. There will be dystonic posturing of the pharyngeal muscles, cervical muscles. It is a case of Sandifer syndrome. Sandifer syndrome generally seen in infants, but it is also seen in adults. It is a treatable condition. The root cause for this is GERD, that is gastroesophageal reflux disease. Sandifer was a British neurologist. Actually, this syndrome was described by Kinsbon, but Kinsbon's guru was Sandifer. So, he published these cases, and this disease was named after his guru as Sandifer syndrome. It is seen in children, especially between 18 to 36 months of age. It is not uncommon in adults also. One should not think that it is a case of seizure. It is a case of Sandifer syndrome, retrocolis, cervical dystonia because of GERD, and they respond to management of GERD, prokinetics. Another case of benign paroxysmal infantile torticollis. See, her chin is deviated to the left shoulder, her head is towards right shoulder. There is a spasm of the right sternomastoid. It's a case of, it's a benign condition. You need not send it for any surgical incision of the sternomastoid. It's a benign condition. And you need not ask for imaging also, including cervical MRI. It's a benign condition. So it's a case of benign paroxysmal infantile torticollis. It doesn't affect the child's future. Another case of kinesiogenic dyskinesia. See the video. See, kinesiogenic means while walking, suddenly the limb becomes stiff. It's a case of primary kinesiogenic dystonia or dyskinesia. So, it is mistaken for seizure activity. Imaging will be normal, EEG will be normal, but the treatment is same as that of seizure activity. Carbamazepine is a drug of choice. It is a channelopathy. So this is last slide. All these conditions are very uncommon, but all these conditions are recognizable with the classical findings. I have seen the Candice sign. I have not seen before. Only for the first time I have experienced the Candice sign. And the facial-brachial dystonic seizure, autoimmune encephalitis. The anti-NMDAR, that young girl, there was no teratoma, positive for anti-glutamate antibody, and she responded to steroids. Sandifer syndrome. Thank you very much. All these cases were treated in the Department of Neurology. Please remember, these cases were not from outside. We, as a team, PGs, faculty members, we struggle a lot for the accurate diagnosis of these conditions. Sometimes, if the patients cannot spend, we spend from our pocket for the accurate diagnosis. The treatment depends on the accurate diagnosis only. So, most of them have recovered. Thank you so much for giving this opportunity.
Genetic disorders are difficult to treat, but majority of the neuronal cerebral conditions, living along the stroke, other things, they are mainly antigen antibody reactions. They are all respond to steroids. That is why needing investigations. See, previously we don't have that much investigations, and now we are getting all the investigations with imaging and also this genetic analysis also. That helps. Yes.
If the patient comes to your clinic, you cannot consider these conditions. You cannot send for these investigations, very expensive investigations. Doubts about the cases? That Sandifer syndrome, very rare, sir. We were taught Sandifer syndrome in pediatrics. I did my MD pediatrics. We know that, but adult presenting as retrocolis following feeding because of GERD, I have not seen, first time. And neurosyphilis with the Candice sign, I have not seen. Tetanus, sir.
GERD associated with neck stiffness, other things, and GERD is always associated with esophagitis. Sometimes esophagitis, we can have the neck stiffness and going, and low back ache in middle. That is also previously that esophagitis is very difficult to differentiate with myocardial also, unless we are having the echoes and other things. Like that, esophagitis and producing neuronal stimulation, neck stiffness might be. That is treating the GERD, that symptoms are also getting reduced. And this, of course, you are lucky to have in the Department of Neurology, and seeing in the government hospital, they will stay there irrespective of the cost and other things. And congrats to have a lot of abnormal. Yes. Image also. So in the olden days, this image, CT scan was not used to available that time. Of course, every medical specialty has advanced, and especially to with the imageology and all these things. Thank you once again.
Wonderful lecture, sir. And I request Dr. Rajan Prasad Babu garu to present certificate to Dr. Sundaracharya, sir. sharing with us for your knowledge and clinical experiences. And please join with us for exotic feast. Thank you very much.